بسم الله الرحمن الرحيم. اولا انا بتوجه بالشكر للدكتور سيد عبد الحميد والاستاذ الدكتور حمدي تمام على الدعوه الكريمه، وبرحب بالقامات العلميه الشامخه اللي معانا، وبرحب بالاصدقاء والزملاء اللي حاضرين معانا. This presentation is in loving memory of my friend and classmate Dr. Mohammed Fathi Amin. Our case is about an unusual finding that we found during cubital tunnel release. This case was done by Dr. Mohammed Rafat and myself. We both of us have no relevant conflict of interest. We are grateful to Dr. Ahmed Abdel, Dr. Islam Futuh, Dr. Ali Ahmed Ali, Professor Hussein Khayat, and Dr. Ahmed Abdel Fattah. Our patient is a 64-year-old right-handed man who presented in February 2022 with numbness and gradual deterioration of sensation in the distribution of the right ulnar nerve over the previous 6 months. There was also gradual weakening of hand grip and medial elbow pain. His medical history was irrelevant, and there was no history of local trauma or surgery. On examination, there was no cubitus varus or valgus. There was clawing of the ulnar 2 digits of the right hand and atrophy of the palmar and dorsal interossei. The tender ulnar nerve could be palpated and rolled within the cubital tunnel, and there was weakness of abduction and adduction of the fingers. Grip and key pinch were weak at the right hand compared to the left. Regarding the special test, Tinel test was positive in the at the cubital tunnel and negative at Guyon's canal, and Froment test was positive. Plain X-ray was unremarkable, and routine blood tests saw only an elevated ESR. Nerve conduction study showed a picture of axonal injury at the right ulnar nerve at the elbow, which was mainly motor, and sensory nerve conduction showed a slowing of nerve conduction at the right ulnar nerve compared to the ipsilateral median nerve. This is the report. So we concluded that this case simply was a cubital tunnel syndrome. And our decision was simply to surgically release the ulnar nerve, and this is a very easy decision. So we took the patient to the operating room and explored the ulnar nerve. After opening the cubital tunnel, a 4.5 centimeter fusiform swelling of the ulnar nerve was found. This is a close-up picture. And a scanty amount of cheesy white material was peeping through the swollen portion of the nerve. And this is also a close-up picture. First, we decompressed the nerve fully. Then we addressed the intraneural lesion. We did tangential shaving of the lesion. And post-operatively, we did not restrict the elbow range of motion, and the obtained material was sent for microbiology and histology, which proved it to be tuberculous caseous material. The patient was referred to chest hospital, which confirmed the diagnosis of tuberculosis and found no evidence of pulmonary tuberculosis, and the standard anti-tuberculous medication was instituted. The patient, however, unfortunately, the patient was lost to follow-up for 1 full year thereafter. Finally, we were able to get him about 1.5 months ago. We managed to regain contact with the patient. I brought him for re-evaluation, and the patient reported that he suffered serious gastrointestinal trouble that he attributed to his anti-tuberculous medication only about 4 months into his regimen. So he discontinued the medication by himself and never reinstituted it again. The outcome after this was partial neurological recovery, which was more sensory than motor. So the discussion. Now we come to the discussion. Various intraneural lesions causing cubital tunnel syndrome were reported in the literature, included intraneural ganglion cysts, hematomas, hemangiomas, and lipomas. In fact, we thought the patient at first sight, we thought it was a case of leprosy, because specifically tuberculous leprosy, because of the known affinity of leprosy to peripheral nerves compared to tuberculosis, which has more affinity to the central nervous system in the form of meningitis and tuberculomas. The earliest case of ulnar nerve tuberculoma was reported as a new clinical entity only 60 years ago. And the pathogenesis of tuberculoma spreading to peripheral nerves is unclear. Other than the ulnar nerve, peripheral nerve tuberculomas reported in the literature included tuberculomas of the optic nerve and optic chiasma, lumbosacral plexus, tuberculomas of the sural nerve, and of the recurrent laryngeal nerve. The previously reported ulnar nerve tuberculomas were only 9 cases, spanning from 1964 to last year, not including our case, which is the 10th case in the literature. This is a summary of the previous studies. The youngest patient was a female 7-year-old, and the oldest one was our patient who was 64 years old. The tuberculoma spanned from the upper arm to the palm, which was in the study by Nucci et al. In 1988. Treatment ranged from medical treatment, which was in one study, to surgical treatment followed by antituberculous medication, and to surgical treatment, excision, with streptomycin wash, followed also by antituberculous medication, and the outcome ranged from full recovery to partial recovery. Most of the cases, about 2/3 of the patients after surgery followed by medical treatment, including our case, showed partial recovery of the neurology. The only case that was treated medically showed partial recovery. So what's unique about our case? The thing which is unique about our case is that all the previous reports, the tuberculomatous lesion was either proximal or distal to the cubital tunnel down to the palm. To our knowledge, tuberculosis affection of the ulnar nerve within the cubital tunnel has not yet been previously reported. In general, the presence of a tuberculoma within the nerve tunnel is an extremely rare occurrence. Cubital tunnel syndrome was associated in the literature with carpal tunnel syndrome was associated with, recorded to be associated with tuberculosis, but however, all the cases reported in the literature were tuberculous synovitis rather than intraneural tuberculoma, either due to tuberculosis, tuberculous bacilli, or atypical mycobacteria. So the lesson learned from this case, personally, clinical assessment and nerve conduction studies may not be enough in evaluation of cubital tunnel syndrome. We should add ultrasound evaluation routinely in order to do 2 things. First one is to dynamically detect nerve subluxation, which is an important cause of cubital tunnel syndrome, and to detect the rare presence of intra or extraneural lesions prior to surgery. However, imaging does not reliably differentiate tuberculomas from peripheral nerve sheath tumors, and I think the use of ultrasound is partially applicable to carpal tunnel syndrome because we see space-occupying lesions more frequently in carpal tunnel syndrome than in cubital tunnel syndrome. This is one of our cases, by the way, which had an angiolipoma within the tunnel. This is an extensive reference list, and this is the Facebook page of our limb reconstruction unit. On the right is the YouTube channel of our department. This is the QR code that leads you to our YouTube channel. I learned this from Professor Mohammed. He does this often, and thank you.